And welcome to those that are joining us for this session of YP Speaks. My name is Desiree Nuffield, and I'm the YP Speaks coordinator with the Young Professionals Chronic Disease Network. So today marks Wednesday, September 23rd, and I'm delighted to have Dr. Kremlin join us this afternoon for our session. I will make a note that the YP Speaks session today is open to those that join, so if you are looking to contribute to our discussion, please feel free to sign in. I'll just request that everyone mutes their mics as well so we don't steal the stage from Dr. Kremlin. To give you an introduction as we move forward, Dr. Kremlin is a researcher with the Nuffield Department of Population Health at the University of Oxford. Kremlin joined the British Heart Foundation Centre on Population Approaches for Non-Communicable Disease Prevention in 2009 to work on the epidemiology of cardiovascular disease and associated risk factors. He also collates and produces statistics for regular publications for the British Heart Foundation, which was awarded the status of the World Health Organization Collaborating Center on Population Approaches for Non-Communicable Disease Prevention in 2013. Dr. Kremlin is the co-director as well of, is the co-director of this collaborating center. He is also the course director for the short course on prevention stages for non-communicable diseases, organized on a regular basis by the British Heart Foundation. He has a PhD from Oxford University on quantifying the impact of policies addressing sustainable healthy diet, and graduated with a Bachelor of Medicine, Bachelor of Surgery from the Faculty of Medicine at Colombo in Sri Lanka. Now, their list continues to go on, so perhaps at this time I will pass the stage, or the figurative microphone, to Dr. Kremlin for anything that I may have missed. You can add to your own CV at this point in time, and I'll happily support you as you move forward. So welcome, and thank you again for joining us today.
Right. Thank you, Desiree, and I think that thank you for that long introduction, and I think we'll straight away get into the presentation. So you mentioned that we have about 15 minutes for the presentation, and then we will have a discussion after that. Is that right?
Yes, correct. And at this time, I'll also mention for those that are watching the live broadcast, feel free to interject with questions as you see fit. Our question and answer application on the Hangout is enabled, and I'll also be monitoring our Twitter feed to see if there's anything filtering in that way.
Right. So, yeah, so as we know, we are going to talk about the links between non-communicable diseases, poverty, and development. So within the next 15 minutes, I will try to explain some of the work we have done, mainly on two fronts. First, what's the current scientific approaches to show the evidence between these links, and then to show you some practical examples of what we have learned from our research work. How can we incorporate prevention and control of NCDs into poverty reduction strategies? So these are the 2 points I want to address during this presentation. Before we go into the specific issue of poverty and NCDs, I want to show you this slide. This is from Boyd Swinburne, published in Lancet in 2011. Any health, any disease, and any intervention to address disease, he categorized into 3 components. First, environments, behaviors, and physiology. So anything we do, any intervention to prevent a disease or to manage a disease, any intervention will fall into one of these categories. To make it easier and more relevant to NCDs, let me put this causal web, which all of you might have seen. So anything we do, any intervention, would be to address the intermediate risk factors such as blood pressure or blood glucose, or they will be to address the behaviors such as diet, physical inactivity, or tobacco use, or more upstream environmental determinants. Now, what Boyd Swinburne...
Dr. Kremlin, can I interject for just one moment? It seems that your PowerPoint slide has just come out of focus, so perhaps I'll just ask that you reshare your screen.
Okay, so what should
My
I do?
apologies about that.
Yeah, share screen, entire screen.
Yes,
Share.
correct.
Is it better?
Yeah, beautiful. So now just running the slideshow.
Right. Okay, so this slide shows that any intervention we do could be either under physiology or behaviors or environments. And what Boyd Swinburne says is that anything around environment, any intervention, we know that they have population effect, greater effect, but they have greater political difficulty. So what happens is most of the intervention tend to be around physiology, addressing risk factors either through drugs, screening, treatment on the right-hand side of this diagram. Now, Harry Rutter shows that if you look at all the research and evidence coming through related to NCDs, most of the evidence is concentrated around the right side of this diagram. All the evidence is about links between these intermediate risk factors and the disease, or interventions to address these intermediate risk factors and disease. We don't see much evidence of interventions for environmental level changes like urbanization, globalization, or socioeconomic status, cultural intervention, how they are having any impact on NCDs. So our evidence base is weak on this area, on the environmental interventions, but we know population effect is greater if we work on that area. Now that is the story for poverty and NCDs as well. We don't have much evidence either to show the links between poverty and NCDs or to understand which strategies would reduce poverty and NCDs. Now, although we don't have much evidence, I think it's rational and logical to say that based on what we have observed, that more people get trapped into poverty because of NCDs. They can't go to work, their bystanders can't go to work, they lose their incomes, and they can trap into poverty if they get NCDs. At the same time, our epidemiological data shows most of the risk factors and disease burden is among the lowest income groups. So because of that, the 2011 political declaration said NCD prevention strategies should work with the development sector or poverty reduction strategies. But we haven't seen the commitment or response.
Just a minute, yeah.
We haven't seen the responses from poverty reduction from the development organizations. Now, reason is, although we say that there is a link between poverty and NCDs, most of the development organizations are not convinced with this. Even from the WHO, they have asked, what's the evidence that we should prioritize NCD prevention in poverty reduction work? Because they say that most of the basic work, such as water, sanitation, communicable disease, is an unfinished agenda, and they should continue to work on that area. So WHO, World Health Organization, asked our research group to do 2 systematic reviews to show the link between poverty and NCDs. Then they can address this evidence gap. So I don't have time to go through everything, but I'm going to show you a few slides just to show you what we are getting, which kind of papers we are seeing through this systematic review. So this is a paper from India published in the British Journal of Cancer and showing the survival by cervical cancer, survival probability in 3 socioeconomic status, low, middle, and high. And as you can see, people who are in the low socioeconomic status have the lowest survival probability. So again, it shows that depending on your socioeconomic status, your disease outcome, cancer outcome changes. This is looking at a disease. If you look at a risk factor, this is from a developed country, England. If you look at the physical inactivity among different income quintiles, the lowest income quintiles or the poorest men and women have the highest physical inactivity. This is for a risk factor. Another risk factor, smoking. This is a complicated graph, but I'll try to explain it a little bit. So in this graph, if you go right on the x-axis, that means there are more people smoking in that country. Each dot represents a country. A red dot means a middle income group, and a blue circle means low income group country. Now, if there's a line on the y-axis at 1, and that is relative inequality in smoking. So any country above the line means that more people in low income groups smoke more, and any dot below the line shows that more rich people smoke more. And what you see is in most of the countries, whether they are middle income or low income groups, in most of the countries, poorer groups smokes more than the high income groups, and except for 3 or 4 countries in the Mediterranean region. So overall, whether we look at diseases or risk factors in developing countries or developed countries, we see higher burden of diseases and risk factors in the poorer groups. Now, what do we need to move forward? The problem is when we look at, so what can we do? Whether these poverty reduction strategies have an impact on NCDs or reducing NCDs, we don't have good evidence for that. The problem is poverty reduction programs are not designed to address NCDs. So their monitoring and evaluation do not measure any health indicators. They look at the number of families moved above the poverty line or something, or employment rates and things like that. And because of that, we can't really compare the methods and compare these interventions to understand